Okay, let's talk about something absolutely fundamental to human health: blood. Specifically, how our bodies make healthy red blood cells and what happens when that process goes wrong. This deep dive is especially for you, the KMR advised community, focusing on key concepts relevant for medical students.
And it's a crucial topic,
Mm.
really. Anemia, a deficiency in healthy red blood cells. It's one of the most common conditions you will absolutely encounter in practice.
Mm.
Understanding its root causes and how to fix them, well, it starts with knowing the essential ingredients and signals the body uses.
Precisely. Today, we're diving into those essentials. Haematinics, think of them as the raw materials like vitamins and minerals and erythropoietin, that vital hormone signal.
Right. Our mission here is to take these key concepts and, well, unpack their uses, how they work at a fundamental level, and the practical points you really need to grasp. Make these complex ideas clear and, clinically relevant.
Okay, let's jump right in by looking at why these substances are so important in the first place. What kind of situations call for using haematinics or erythropoietin?
Well, the primary clinical reason is, as we mentioned, treating anemia. Different types of anemia require different agents, and knowing which one to use is really step one.
So what's the big one? Especially common here in India.
That would be iron deficiency anemia. The source material explicitly states this is the most common cause of anemia, specifically in India.
Okay.
When there's not enough iron, the body just can't make enough hemoglobin. This results in red blood cells that are characteristically smaller and paler than normal. That's what we call microcytic and hypochromic.
Microcytic hyperchromic, got it.
The solution there is, well, pretty straightforward. Provide iron.
Okay, so that's a building material problem. What about another major type, megaloblastic anemia?
Yes. This one arises from a deficiency in either vitamin B12 or folic acid, or sometimes, both.
And the name megaloblastic suggests the cells look different again, right? Bigger this time.
Exactly, yeah, larger. The problem here isn't so much making hemoglobin itself, it's more about making the cells properly.
Hmm.
Deficiency in B12 or folate disrupts DNA synthesis, leading to the production of abnormally large red blood cell precursors. They don't mature correctly, and that causes the anemia.
Fascinating how two different deficiencies can lead to the same type of cell abnormality because they hit the same core process, DNA building.
Precisely, it's a key connection.
Now, erythropoietin, you mentioned it's a hormone deficiency in a specific condition.
Yes. Erythropoietin, or EPO, is crucial for the anemia of chronic kidney disease, CKD. Healthy kidneys produce most of our EPO, signaling the bone marrow to ramp up red blood cell production.
Okay.
When kidneys are damaged in CKD, EPO production falls. This means you have to replace that missing signal with EPO therapy. It's a completely different mechanism than lacking raw materials.
So iron and B12 folate are about the ingredients, the building blocks, while EPO is about the signal telling the factory, the bone marrow, to get to work.
That's a great way to put it.
Beyond treating active anemia, are there other uses? Prophylaxis, maybe?
Absolutely. These agents are also used for prophylaxis, basically preventing anemia in people at high risk. Think pregnant women, infants, individuals with chronic illnesses causing blood loss, women with heavy menstrual bleeding, or patients recovering after significant acute blood loss.
Makes sense. Making sure they have the reserves or the boost needed. And the term adjunct in rapid hematopoiesis. What's that about?
That refers to supporting the bone marrow when it's trying to produce blood cells very quickly. For example, during treatment for megaloblastic anemia or hemolytic anemia, you're essentially giving the bone marrow all the tools it needs for a fast recovery.
Okay. And the notes mention some rarer uses, too.
Yes, there are specific anemias linked to deficiencies in copper, pyridoxine, that's vitamin B6, or riboflavin, vitamin B2. But the critical point here is you only use these if you have specifically diagnosed that particular deficiency.
Right, not just for any anemia.
Exactly. They aren't general anemia treatments.
That makes perfect sense. Treat the specific cause you find. So understanding these clinical indications is absolutely key to selecting the right agent for the patient.
Precisely. It guides your initial thinking when faced with a patient presenting with anemia.
Let's talk about the agents themselves then. The notes provide a classification of these haematinics and erythropoietin. Who are the main players we need to know?
They're broadly grouped by type. First step, we have iron preparations, and these are divided into oral and parenteral forms.
Okay, for oral iron, what are some common examples we should recognize?
You'll definitely encounter salts like ferrous sulfate, ferrous fumarate, and ferrous gluconate. There's also carbonyl iron and ferric polymaltose.
And brands common in India.
Yes, the notes-mentioned brands like Fursolite, Autran, Fefol, Ferricard, and Polyron. You'll likely see these around.
Any key clinical points about these oral forms?
Yeah, a practical one. Ferrous salts generally have better absorption, but carbonyl iron is often preferred because it tends to cause fewer side effects. It's often better tolerated.
Tolerability. That's huge in practice, isn't it, for getting patients to actually take the medication?
Absolutely. Compliance is key.
What about parenteral iron, the injected forms?
Examples here include iron dextran, iron sucrose, and ferric carboxymaltose. You might see brands like Imferon, Uniferon, and Insacarb.
And the clinical note for these?
The crucial thing is that parenteral iron is reserved for situations where oral iron just isn't an option. Maybe the patient can't tolerate the side effects even after trying different types, or they have conditions like inflammatory bowel disease, IBD, that prevent proper absorption from the gut.
So oral is usually the first line. Parenteral is for specific situations. Got it. Next up, vitamin B12.
The important forms here are cyanocobalamin, hydroxycobalamin, and methylcobalamin. Common brands include Neurobion, Optineuron, Polybion, and Bacosols.
Any preference for injection?
Yes, for injection, hydroxycobalamin is often the preferred form.
Okay. And folic acid?
This includes folic acid itself and also folinic acid, which is also known as leucovorin. Brands like Folvite are very common, along with Fasevorin and Recoverin.
And folinic acid has a specific role.
It does. Folinic acid has a special clinical use. It's particularly effective counteracting the toxicity of the drug methotrexate. You'll see methotrexate used in oncology and rheumatology, so that's a useful connection.
That is a useful detail to remember. And finally, erythropoietin itself.
Right. These are recombinant forms like apoetin alpha and apoetin beta, and also darbepoetin, which is a longer-acting version. Brands like Hemax, Ypres, and Xyrop are examples.
And their main uses?
As we discussed, primarily for anemia related to CKD and certain anemias caused by cancer chemotherapy.
Right. And those rarer others like copper and pyridoxine.
Again, just to reiterate, they're mentioned, but it's important to remember they are only used when a specific deficiency is confirmed. You wouldn't just grab these off the shelf for a general anemia.
Okay. So knowing this list of players and their common forms really helps demystify prescriptions in clinical discussion.
Absolutely. It gives you the vocabulary to understand what's being prescribed and why.
Okay, now for the how. Let's peel back the layers and understand the mechanism of action. How do these substances actually help the body make blood?
Understanding the mechanism is, well, it's like understanding the engine of a car. It explains why a deficiency causes specific problems and how the treatment actually corrects them.
Makes sense. Let's start with iron. How does iron go from, say, your diet or a pill to becoming part of a red blood cell?
It's definitely a multi-step journey. First, absorption. Iron is absorbed primarily in the duodenum and the upper jejunum of the small intestine, and it's absorbed best in the Fe or ferrous form.
So the chemical state really matters for absorption.
It does, very much so. Once absorbed, iron needs a ride in the bloodstream. It's transported bound to a protein called transferrin.
Transferrin, like a taxi for iron.
Kinda, yeah. Think of transferrin as the dedicated courier for iron. This courier delivers the iron to the bone marrow, where developing red blood cells have specific transferrin receptors to grab the iron.
Like a specific delivery dock right on the factory floor.
Exactly. Inside these erythroid precursors, the iron is incorporated into hemoglobin. That's the protein that carries oxygen, of course.
Right.
Any iron that's not immediately needed is stored, mainly in the liver, spleen, and bone marrow, as ferritin and hemosiderin. These are your reserves, ready to be tapped into when needed.
That's a pretty complex but efficient system. Now, vitamin B12, how does it fit into the picture? Its role seems different.
B12's role is fundamentally different, yes. Its absorption is a bit more complicated, too. It happens mainly in the terminal ileum, that's the very end of the small intestine.
Okay.
And crucially, it requires intrinsic factor, a protein made in the stomach. No intrinsic factor, no B12 absorption from the gut.
Ah, that explains pernicious anemia then, where the stomach doesn't make intrinsic factor.
Precisely. That's the link. Once absorbed, B12 is transported in the blood by another protein, transcobalamin tazecin. Inside cells, B12 acts as a vital coenzyme for specific metabolic reactions. Yeah, particularly those involved in DNA synthesis. Specifically, it's needed for the methylation of homocysteine to methionine, which is part of the cycle that regenerates the active form of folate.
Wait, hang on. So B12 is needed to keep folate working properly for DNA synthesis?
Yes, this is a really key insight. Without B12, folate gets essentially trapped in an inactive form. So even if you have plenty of folate floating around, you can't use it effectively for DNA synthesis.
Wow.
This impaired DNA synthesis affects rapidly dividing cells most severely, like those in the bone marrow, leading to the production of those large, abnormal red blood cells, the megaloblastic picture we talked about.
So they both cause megaloblastic anemia because they both disrupt DNA synthesis, but B12 does it by, like, disabling folate's role in one key step. That's quite clever, biochemically speaking.
It is. And folic acid itself works by being converted into tetrahydrofolate, or THF. That's its active form. THF is essential for donating one-carbon units in various reactions, including the synthesis of purines and pyrimidines, the actual building blocks of DNA. It's absorbed mainly in the proximal small intestine.
So B12 and folate are like two essential interlocking gears in the DNA synthesis machinery. Both are needed to build new cells correctly.
That's a really good way to picture it, yeah.
Yeah.
Now, erythropoietin's mechanism is quite different. It's all about signaling.
The hormone signal.
Right. It's a glycoprotein hormone produced mainly by cells in the kidneys, specifically in response to hypoxia, or low oxygen levels in the tissues.
So the kidneys sense low oxygen and basically send out an alarm signal for more oxygen carriers.
Exactly. That EPO signal travels through the blood to the bone marrow. There, it binds to specific receptors on erythroid progenitor cells. These are the earliest cells committed to becoming red blood cells.
Okay.
This binding triggers a cascade of events inside the cell, using a pathway called the JAK-STAT pathway. This essentially tells these cells, divide, mature, and produce more hemoglobin.
So it's like a hormonal go signal, turning up the production line in the bone marrow factory. And in CKD, that signal is weak or just missing.
Correct. Understanding these mechanisms really ties together why each deficiency leads to a specific problem and, critically, how the corresponding treatment targets that exact problem.
Okay, that makes a lot of sense. We know what they are and how they work. Now let's look at pharmacokinetics, PK. How does the body handle these substances once they are administered? Absorption, distribution, metabolism, excretion, all that.
PK is absolutely crucial for understanding dosing, the routes of administration we choose, and potential issues that might crop up.
Let's start with oral iron PK. What are the key points?
Absorbed, as we said, mainly in the duodenum and jejunum. It binds to transferrin for transport around the body. Anything not absorbed just passes through and is excreted in the feces. There's actually very little iron excreted from the body, otherwise it's tightly conserved.
And the practical point for taking it.
Right. A key practical point for you is that absorption is technically best on an empty stomach, but you need to be prepared for significant GI side effects. That's a common issue.
Yeah, we hear that a lot. What about parenteral iron PK?
Given IM or IV, it obviously bypasses the gut absorption issues. It's processed by the reticuloendothelial system. These are cells primarily in the liver, spleen, and bone marrow, which can handle larger amounts of iron compared to gut absorption. It's not really excreted.
And the safety note.
A critical safety note here, particularly for the older formulation iron dextrin, is the mandatory test dose. This is because of the risk of a severe allergic reaction, anaphylaxis. Really important.
Okay, that's a high-stakes PK detail to remember. Vitamin B12 PK.
Oral absorption, again, requires intrinsic factor in the terminal ileum. B12 is unique in that the body stores quite a bit of it, primarily in the liver. That's why B12 deficiency can sometimes take years to develop after the cause begins.
Years, wow.
Yeah. It's mainly excreted through bile with significant enterohepatic circulation, meaning it gets recycled back into the gut, and any excess is excreted in urine. The key clinical note, especially relevant in India, is that for pernicious anemia or other malabsorption states, you must give B12 by IM or SC injection. Oral forms just won't be absorbed effectively.
Explains why we see so many B12 shots being given. Folic acid PK?
Absorbed well in the proximal small intestine, generally. It's distributed to the liver and other tissues, and excess is excreted in the urine. Oral administration is usually perfectly fine unless there's a clear malabsorption issue going on.
And erythropoietin PK?
Typically given subcutaneously, SC, or intravenously, IV, it acts directly on bone marrow receptors. It's a protein hormone, so it's metabolized like other proteins. Only a minimal amount is excreted unchanged in urine. The note about SC being preferred is interesting. It often allows for a lower total dose compared to IV, potentially due to slower absorption, giving more sustained levels.
So PK really tells us how we give these drugs and why certain rates are absolutely necessary in specific conditions.
Exactly. It dictates dosage forms and fundamentally informs our therapeutic strategies.
Okay, now let's talk about the downsides. While necessary, these medications aren't free of adverse effects. What should we be watching out for?
Absolutely. Awareness of potential side effects is crucial for patient safety, monitoring, and managing treatment effectively.
Oral iron is kind of notorious for GI issues, right?
Yes, very common. The source lists things like general upset stomach, constipation, sometimes the metallic taste, and black stools, which can sometimes worry patients if they aren't warned. Liquid preparations can also stain teeth.
Why does that happen?
It happens because of direct irritation to the mucosal lining of the GI tract. Managing this often involves starting with a low dose, increasing it gradually, and if needed, taking it after food, even if that slightly reduces absorption. It's a trade-off.
Unnecessary compromise sometimes for sure. Parenteral iron side effects. What are the risks there?
At the injection site, you can get pain and sometimes pigmentation, especially with IM forms. Systemically, fever is possible. But the big concern, particularly with iron dextrin, is anaphylaxis, that severe allergic reaction we mentioned.
Right.
Iron given too fast can also cause hypotension, a drop in blood pressure. These are linked to hypersensitivity reactions or sometimes effects of free iron getting loose. That mandatory test dose before iron dextrin is specifically to check for hypersensitivity before giving the full therapeutic amount.
Reemphasizing that test dose really highlights how serious that reaction can be. How about Vit B12 and folic acid? Generally safer.
They are generally quite safe, yes. With injectable B12, rare allergic reactions can occur, sometimes thought to be linked to preservatives in the formulation rather than the B12 itself. Folic acid is also very safe, with rare allergic reactions primarily seen with injections.
And the advice for B12 injections?
The recommendation to stick to IM or SC for B12 where needed helps avoid the very rare anaphylactoid reactions that have been reported with IV B12 administration.
Good to know they're mostly well tolerated. And erythropoietin adverse effects. These sound potentially more serious.
They can be, yes, and require careful monitoring. The notes list hypertension, increased blood pressure, and an increased risk of blood clots or thrombosis. Also, flu-like symptoms can occur, and rarely seizures have been reported.
Why do those happen?
These effects are thought to be related to the rapid increase in red blood cell mass and blood viscosity, making the blood thicker, essentially. Managing this involves careful dose titration, starting low and adjusting based on response, and close monitoring of the patient's blood pressure and hemoglobin level.
So you're kind of trading the risks of anemia for potentially other risks if it's not managed very carefully.
It's always a balance of risks and benefits in medicine, isn't it? And it requires careful, ongoing monitoring.
Definitely. Let's switch gears slightly. When should we absolutely not use these agents, the contraindications, and are there common drug interactions we need to be mindful of?
Knowing the contraindications and interactions is fundamental to preventing harm and ensuring treatments actually work effectively.
When is iron contraindicated? When should we avoid it?
Okay, definitely if a patient has hemochromatosis, which is a condition of iron overload, giving more iron would clearly be harmful there.
Makes sense.
Also, generally in hemolytic anemias, where red cells are being destroyed prematurely, unless there's also a proven coexisting iron deficiency. Otherwise, the iron isn't the primary problem. And parenteral iron specifically should usually be avoided during active bacterial infections, as there's a theoretical concern it could fuel bacterial growth.
Right. Erythropoietin contraindications.
Uncontrolled hypertension is a key one. Since giving EPO can increase blood pressure, you really need to get the BP under control first. Also, of course, known hypersensitivity to the product or its components.
Okay. What about interactions? Any common culprits that interfere with iron absorption or function?
Yes, antacids are a big one. They decrease iron absorption significantly. The solution is usually simple, though. Give the iron at least 2 hours apart from the antacids. Timing is key.
Timing again. What about iron and tetracycline antibiotics?
That's a significant interaction. They decrease the absorption of both the iron and the tetracycline. They bind to each other, so they should generally not be given at the same time if possible.
Good to know. What about vitamin C with iron? I've heard that actually helps absorption.
That's true. Vitamin C or ascorbic acid can actually increase iron absorption, primarily by helping to keep iron in the more easily absorbed ferrous Phe state. It can sometimes be used intentionally to try and enhance iron uptake, though its clinical impact can vary between individuals.
Interesting. And folic acid interactions, particularly with epilepsy medications.
Yes, that's an important one. Certain anticonvulsants, like phenytoin, can interfere with folate metabolism, potentially reducing folate levels. Conversely, high doses of folate might affect the metabolism of the anticonvulsant. This can potentially decrease the effectiveness of both drugs. So, in patients on these medications, you often need to monitor folate levels and provide supplementation if necessary.
Okay. Finally, the really important relationship between erythropoietin and iron. You touched on this.
Absolutely critical. Can't stress this enough. Iron deficiency limits the patient's response to EPO therapy. Think about it. If the body doesn't have enough iron building blocks, even the strongest EPO signal from the drug can't make new hemoglobin and red cells effectively.
Right, the factory needs raw materials.
Exactly.
Yep.
So you must ensure the patient's iron stores are adequate. One, check their ferritin and transfer in saturation, or TSAT, and actively supplement iron if they are low, either before starting or during EPO therapy.
That's a fantastic clinical pearl linking two major parts of this deep dive. These interactions really highlight why getting a detailed medication history is so vital.
It absolutely is. You need the full picture.
Okay, let's try and bring this all together with practical points. Typical dosages, essential clinical pearls, and briefly, what to do if there's toxicity.
Right, these are the details you'll use every day when managing patients with these agents.
What's a typical dose for oral iron in adults?
The target is usually around 100, 200 milligrams of elemental iron per day. And it's important to remember that's the actual iron content, not the total weight of the salt tablet. Like ferrous sulfate, 325 milligram, only has about 65 milligrams of elemental iron.
Good distinction.
You often divide the total daily dose, maybe 2 or 3 times a day, to potentially improve absorption and tolerability. And while empty stomach is ideal for absorption, taking it with food might be necessary if those GI side effects are just too severe for the patient.
Elemental iron is the key number.
Got it.
Parenteral iron dosage. Is there a standard dose?
It's often calculated more precisely based on the patient's specific iron deficit. There are formulas, like the one mentioned, 4.4 times body weight in kiloj times the patient's hemoglobin deficit in GDL. But the key pearl remains. Reserve this route for patients who really can't use or don't respond to oral iron.
Okay. VIT B12 injection dosing. How is that typically done?
For intramuscular IM, or subcutaneous SC injection, a common approach is 1 milligram, or 1,000 micrograms, daily or every other day for the first week or two to build up stores rapidly, then tapering to weekly and eventually monthly injections for long-term maintenance. This is especially important in conditions like pernicious anemia, where oral absorption is permanently impaired.
Right, because oral is unreliable there. Folic acid dosage.
For treating an established deficiency, typically 1 to 5 milligrams per day is used. For preventing deficiency, like routinely during pregnancy or in patients with chronic hemolytic anemias, a lower dose around 0.4 or 0.5 milligrams per day is common, sometimes up to 1 milligram.
Okay. And erythropoietin dosing and targets.
Dosing varies quite a bit depending on the patient and response, but often ranges from 25 to 100 units per kilogram, given SC or IV, maybe 3 times a week initially. The goal isn't to push the hemoglobin super high, usually targeting a level around 10 to 11 GDL, maybe up to 12 GDL at most.
And the absolutely essential pearl here again.
Always supplement iron if needed. Check iron status regularly. EPO just won't work effectively without adequate iron.
Let's cover some of those critical, general clinical pearls from the notes. How quickly should we expect to see a response when we start treatment for anemia? What should we look for?
A key early marker is the reticulocyte count. Reticulocytes are young red blood cells pushed out by the marrow. You should expect to see a rise in the reticulocyte count within about a week, maybe 7 to 10 days, of starting effective therapy like iron or B12 folate.
So that's the first sign the factory is ramping up.
Exactly. Hemoglobin levels typically start increasing more gradually after that, maybe by about 1 gram per deciliter every 2 to 3 weeks. It takes time to build up the red cell mass.
That timeline is very practical for monitoring progress. How long should we continue iron therapy once the patient's hemoglobin level is back to normal? Should we stop right away?
No, definitely not. You need to continue iron therapy for typically 2 to 3 months after the hemoglobin level has normalized.
Why so long?
This is crucial to replenish the body's iron stores, the ferritin levels we talked about. Correcting the hemoglobin fixes the anemia, but replenishing stores prevents a rapid relapse.
Okay, rebuild the reserves. Now, one of the most important warnings, you mentioned it briefly, but let's hit it again, giving folic acid alone in undiagnosed anemia.
Yes, this is absolutely critical and incredibly high yield for exams and practice. Folic acid should never be given alone if B12 deficiency is possible or hasn't been ruled out.
Why is that so dangerous?
While folate might partially correct the anemia, the blood picture might look better, it does not fix the underlying neurological problems caused by B12 deficiency. In fact, by improving the blood count, it can mask the ongoing neurological damage, allowing the neuropathy to progress unnoticed, potentially becoming irreversible.
Wow, okay. So always rule out B12 deficiency first, or give them together if unsure in investigating.
Correct. Or treat empirically with both if you suspect megaloblastic anemia but can't wait for B12 levels. It's a critical safety point.
And we've mentioned it, but the notes reemphasize for erythropoietin.
Yes, with EPO. Always correct iron deficiency before starting or during therapy. They are absolute partners in building red blood cells. Check and maintain adequate iron stores.
Okay. Briefly, what happens if someone gets too much of these, especially iron? Is there toxicity?
Yes, particularly with iron. Acute iron toxicity, often from accidental ingestion by children, is a serious medical emergency. It can cause severe nausea, vomiting, abdominal pain, bloody diarrhea leading rapidly to shock, metabolic acidosis, and potentially liver damage or failure.
What's the action plan?
Management involves supportive care, trying to remove unabsorbed iron from the stomach, like gastric lavage if appropriate, and using a specific antidote called dysferrioxamine. This is an iron chelator. It binds the excess iron so it can be excreted.
And chronic iron overload.
Chronic iron overload, like in hemochromatosis or from multiple transfusions, causes iron deposition and damage in organs like the liver, heart, and pancreas over time. This is managed differently, usually with regular removal of blood phlebotomy or sometimes long-term chelation therapy.
Okay. And EPO toxicity. What are the main concerns there?
Primarily linked to pushing the hemoglobin level too high or raising it too quickly. This increases the risk of hypertension and thrombosis, blood clots. The action is to reduce the EPO dose or hold it temporarily and closely monitor blood pressure and hemoglobin levels, aiming for that target range of 10-11 or 10-12 GDL.
These practical points are just invaluable for anyone involved in patient care, especially, for medical students learning how to actually apply this knowledge day to day.
They truly are. They bridge the gap, bringing the mechanisms and the PK to life in the context of real patient management.
Absolutely. To wrap up our deep dive then, let's highlight the absolute must-know high-yield points, the facts you should definitely carry forward from this discussion.
Right. Think of these as the concepts that will likely appear frequently on exams and are absolutely essential for understanding and safe practice.
Okay, high-yield iron facts. What should stick?
Best absorbed on an empty stomach, but GI side effects are common. Absorption is enhanced by vitamin C and significantly reduced by things like antacids, phytates found in many plant foods, and tetracycline antibiotics. Also, remember which groups typically have increased iron requirements: pregnancy, infancy, and menstruating women.
Key differentiator for B12 deficiency versus folate.
The presence of neurological symptoms. That's the classic way to help distinguish B12 deficiency clinically from pure folate deficiency, which typically doesn't cause neuropathy. Remember that connection.
And for erythropoietin, the main takeaways.
It's the mainstay treatment for anemia in chronic kidney disease, CKD. And you absolutely must monitor for hypertension and ensure the patient has adequate iron stores while they're on therapy. Check that iron.
The notes also included a great final exam checklist summary. Let's quickly hit the key points from that. Mechanisms of action in brief.
Okay. Iron is primarily for hemoglobin synthesis. B12 and folate are essential for DNA synthesis, remembering B12's crucial role in activating folate. And EPO works by stimulating erythroid cell proliferation and differentiation in the bone marrow.
Key drugs to keep in mind, the main players.
Ferrous sulfate as a common oral iron. Iron sucrose or ferric carboxymaltose, representing the safer FOV irons. Hydroxycobalamin as the preferred injectable B12. Folic acid and epoetin alpha or beta.
Main adverse effects to really watch for.
GI upset from oral iron is very common. The risk of anaphylaxis with parenteral iron, especially the older dextrin formulation, and hypertension is a significant risk with EPO therapy.
Crucial monitoring parameters. What do we need to track?
Hemoglobin levels, obviously. The reticulocyte count to see if the bone marrow is responding early on. Ferritin and transferrin saturation, TSAT, to assess iron stores, especially with EPO use. And blood pressure, particularly when initiating or adjusting EPO doses.
And finally, knowing the right clinical use cases. Putting it all together.
Yes, exactly. Matching the agent to the specific type of anemia and the patient's overall situation. So using parenteral iron in patients with significant malabsorption like IDD, giving B12 by injection in pernicious anemia, and reserving EPO primarily for anemia in CKD or in chemotherapy settings.
And one last look at those vital black box warnings mentioned. They're important.
Yes, the notes emphasize these for a reason. For parenteral iron, particularly iron dextrin, there's that risk of serious, potentially fatal anaphylaxis. A test dose is mandatory before the first therapeutic dose.
Right. And for erythropoietin.
Erythropoietin has an increased risk of serious cardiovascular events like heart attack, stroke, blood clots, and increased mortality if you raise the hemoglobin too high, specifically above 11 or 12 GDL, or raise it too quickly. Careful titration to the lowest effective dose is key.
And that crucial point again for folic acid.
Yes, that it can mask the diagnosis of vitamin B12 deficiency by improving the anemia while allowing neurological damage to progress. It should never be used alone in undiagnosed megaloblastic anemia.
These are truly the high-yield, actionable items that bring this whole topic into sharp focus for clinical practice.
They absolutely are. They're the cornerstones of managing anemias effectively and safely with these important agents.
And that brings us towards the end of this deep dive into haematinics and erythropoietin, focusing on the key concepts, especially for you medical students out there.
We've explored their essential uses, the different forms available, how they work right down at the cellular level, how the body handles them pharmacokinetically, potential side effects and interactions, and crucially, those practical clinical points that bridge the gap between textbook theory and actual patient care.